As you can see the granuloma annual, so as you can see, this is all circular and shiny, and the inside is white. So they mainly present in the circular shape, then they're shiny. Shiny part is important, and then the inner part is like a little bit normal. So mainly the edges are a little bit hypertrophy, so they are a little bit, outgrowth. So you can see that they are a little bit overgrown. So inside is normal, and then the outside is side is normal. This is uncle cyst, umbilical granuloma, and then amphilocystic cyst. So you can see this one is this one. So the TGA, the transposition of heart, is basically greater artery, sorry. Then TOF, that was egg-shaped heart, and this one is basically boot-shaped heart. Then the Epstein anomaly, box-shaped. Then the flask shaped, this is basically pericardial effusion. Then the egg shaped, this is basically constricted pericarditis. Then the snowman, then the coarctation of aorta, 3. So this everything is written together. Then again the ECG and everything, okay? So I mean everything is repeated now. So we did couple of the things from the pictures. I mean there are some pictures that is still not mentioned in this one scenario. So try to do those ones like a lot of x-rays and ECG. I'm still looking for that PDF. I could not find that one. Let me figure out and then I will share that one, okay? So just give me an of this one. Okay, so we were talking about the chest pain. We did now ECGs. Now we are coming back to where we were stopping. So chronic rhinitis. Again, when we are talking about family medicine, please keep it in your head. You are family physician. You just need to do those things that you need to remember. So I told you how the Frankman risk score work, and I sent it in the group that how you need to remember the nothing but just the values and how much you are going to do the screening point. So that's why everything is very easy. So all you don't need to go into very detail of everything. Then we are talking about this one. When we are talking in this one, you have to remember the cold and flu difference. What is cold and what is flu? I mean, sometimes we do mix up this one. Then flu has more high fever. The cold does not have high fever. Exhaustion is more in flu than as compared to cough, because in flu we are coughing, sorry, not coughing, sneezing, and there is dry and all that. So that makes you exhausted. In the flu, the throat is fine, but in the cold, there is sore throat. Then cough is dry and sorry, nose and dry and clear. Flu makes you more achy, appetite decrease, muscles achy, and then the chills is there present in the flu. But as compared to cold, there is nothing. Then we are looking for the common cold. In this one is basically this called be stress, fatigue, or anything that can be triggered. Symptoms could be congestion, malaise, headache, myalgias. Signs could be the mucosa, lymph nodes, or there is basically the chest pain, chest exam. It could be normal, and then it's a long come along with ENT problems, sinusitis, those ones. So usually that is the symptoms that's it's viral. It usually subside by itself. All you have to do is hand washing. So please keep it in your hand. We do talk about mask and everything, but we forgot to talk about the hand washing. Then the avoidance of the hand to mucus contact and use of the surface disinfectant and influenza vaccination you can give them. Then the rest, hydration, gargling, and steam inhalation and all. Then antipyretics and cough decongestion and decongestant. So there's no antibiotic that can be given for this one. Then we already discussed the concussion and mild traumatic injury, the concussion, and then other one. Then comes the contraception. I think we already discussed the contraception, and you need to remember the emergency contraceptive, which emergency contraceptive works for them. The plan B works really well. And then for more than 72 hours, we go for the copper IUDs. Then comes the cough. A cough can be mainly asked with the differential diagnosis. And please keep it in your head that beta blockers and ACE inhibitors, please keep about this one. Beta blockers and ACE inhibitors do cause dry cough. Okay. Then comes the dementia and delirium. So for the dementia and delirium, we know the difference between them, and we do the MMSE and MOCA. We were talking about which one is best. So best screening test is MOCA. Please keep it in your head. This can be asked that how will you check the uh, like the conscious state of the patient. So basically we do the mocha. Mocha is the best screening test, but if they ask for a quick one is mini cog, usually which asks them to recall things. And then if they are able to recall, this is basically good. If not, then, we give them scoring according to that one. Then checking for the liver, alcohol, all of VDRL, syphilis, HIV, CT scan, folate, vitamin B12, so all of those ones. How do you treat and prevent the reversible causes? Orientation, education, counseling, sport, pharmacological, and then 20% is basically clinical depression. Then comes the depression, how you're going to approach the depression. Please keep it in your head whenever you are talking about depression. Talk about the homicidal and the suicidal thoughts, psychosis, substance use, anxiety, other bipolar bereavement, and then partner violence, and then postpartum depression. So we do approach that one and do the assessment for the suicide one. Then again, we are going to do the mini cog or the MMSE or MOCA. Then the treatment is basically full remission of the treatment and acute treatment. You have to go for the CBT, then 12-month CBT along with the management, and then how often the antidepressants start working. When are you going to check for? When are you going to do the add-on therapy? So those all are important. There is one thing here. Mhm. So there is a MSH caps. That's how you check for that one. Depressed mood, sleep, interest. So they can ask you the questions, which questions you would like to ask. So mainly, if you can skip anything, don't forget about the suicidal ideation. Okay. Then when you're talking about diabetes, if you want to do diabetes, you can do it from here. If you want to do a little bit more detail, then you can do from endocrinology. I did from endocrinology because I have to cover the CDM. I'm not sure in your part how much it can be asked, but usually what they do like to ask in the diabetes, they do like to ask you step by step approach. If the fluid is given, what is the next approach you would like to do? So if you do it from here, it's not enough. You have to do it from the endocrinology, and I will let you know where you have to do it from. Okay, so that's not important. Then assessment and monitoring. When are you going to check for which test in at which level? So for your understanding, all you need to remember is we are going to start with all history and physical examination. Although we are going to do the monitoring 3 month, HbA1c, also checking for the creatinine, BUN, albumin, urine albumin and creatinine ratio, and EGFR. That's what we do every 3 months. Okay. Then after every 3 months, we do yearly. Yearly, what we do is basically checking for the foot examination. Then after 5 yearly, we check for the, or in the type 2 diabetes, we check for the ophthalmology consult yearly. So we're checking for all of those steps comes next second. But 3 month program is checking for all the blood tests, and where we are checking all of the A1C, lipid profile is done, ACR, and all of that one. So then diet can be reduced, the A1C level. So it can be the one that is covered with this one. So you can see from here at diagnosis of type 2 diabetes, start lifestyle modification. If there is more than 6, we usually ask them to start the lifestyle modification. And if this is more than 6.5, in those cases, we do plus minus metformin. 6.5 is basically the HbA1c level, okay? A1c is less than 8.5. Now we are considering 8.5 as the thing. 8.5, if not at a glycemic target 2 to 3 mole, then start the metformin. It means that it's more than 6.5, but less than 8.5%. But if this is 28.5%, then start metformin immediately, and initial combination with another anti-hyperglycemic. So usually we go for the gluclazide. Okay, I mean, that's how our practice works, but yeah, you can see which one is best for them. Then in the hyperglycemic with metabolic decompensation, those ones we go for insulin along with metformin. If not at the glycemic targets, then add another agent best suited to the individuals by the prioritizing the patient characteristics. Then patient characteristics, what are the patient characteristics? Very important. The one for the cardiovascular disease, the best one is SGLT2 inhibitors that works really well with the cardiovascular disease. Please keep it in your head. This can be asked like with diabetes, if someone has cardiovascular disease, which one is best? Although metformin has been started. So in that case, the answer is SGLT2. The degree of hyperglycemia, risk of hypoglycemia, overweight, cardiovascular comorbidities, and then risk assessment. Then considering the A1C, hypoglycemia, all of that you have to keep in your head. Now, what you need to remember from here, or what at least I remembered from here, you need to remember which one is cost effective. All you need to remember which one is all like the best one. Okay. Then we are talking about the one. So the glucosidase inhibitors is basically acarbose, which is basically rarely and affect in the cardiovascular outcome. There is no. So improve postprandial glucose and there is side effects of that one. So let's start with the most important one. So we are going to talk about the SGLT2 because it works really well with the cardiovascular disease. So if anyone has a cardiovascular disease, usually we go with the SGLT2. Now, when we are talking about SGLT2, what are the other side effects? It causes infections. What kind of infection? Genital infections, UTIs, and do affect the kidneys as well. So when we are talking about the genitals, UTI, you will get an idea that we are talking about the kidneys. So it can cause the kidneys and hypotension because this is good with cerebrovascular disease, so it causes hypertension. And then diabetic ketoacidosis may occur with no hyperglycemia. Then the dapagliflozin not be used if the bladder cancer. So it can be directly asked which drug cannot be used in the bladder cancer. Which one is it? The dapagliflozin. Okay. So for your understanding, all you need to remember is which one is cardiovascular disease, which one is that one SGLT2. SGLT2 causes what? Infections, and it can affect your kidneys as well. Now we're talking about the sulfonylurea. Sulfonylurea causes the only drug that causes high amount of hypoglycemia is sulfonylurea. So you have to be very careful with that one. Then we are talking about the GLP or DPP. GLP is very good one and usually used here, and it's caution with the heart failure, although it works really well everywhere and it has less side effects, but the problem is very costly. So the good ones is acarbose, SGLT2, thiazolidinediones. They are the one that is very cost effective. Even the sulfonylurea is something that you can consider in many people, especially it can cause hypoglycemia, so it's avoided in the older people. So please remember the cost effective part because it can be asked if you are a good doctor, you need to know which one are the cost effective ones. Then the solid thiazolidinediones, it shouldn't be given in the cardiovascular conditions. So what you need to remember if what what medications can be given with the heart condition and what medication should be avoided with the heart condition. So what medications can be given? The medications that can be given is basically the SGLT2, and what should be avoided, the thiazolidinediones should be avoided with that one because it causes that one. But which one is the cost effective? The sulfonylurea, but it causes hypoglycemia. Otherwise, insulin, GLP is one of the best one and used a lot in Canada, okay? Because it has less side effects. Then not hypoglycemic targets. In those cases, you have to switch on to different ones. So, but there is what is this? Which class, like which medicines belong to which class. So metformin is biguanide, then thiazolidinediones, which one are those ones? The rosiglitazone. A glucoside inhibitors is the acarbose. The non-sulfonylurea is basically sitagliptinide or the atinglinide. Then the sulfonylurea is glyburide or the gliclazide. I told you we used a lot of that one, but it causes because it's cost effective. So that's why in Canada, we usually after metformin go for the gliclazide. People you do like it a lot. Why? Because of the cost effectiveness. But at the same time, you have to tell them to monitor their sugar levels. Then DPP is basically sitagliptin. Sitagliptin is also used a lot for the weight loss purpose. If someone does not want to go for there's something that can be asked. Okay, which drug is good for the for the weight loss? So in that cases, we go for DPP. Sitagliptin helps with the weight loss as well. Then SGLT2 is the canagliflozin, and those one. Then comes the injectables GLP, semaglutide. So GLP, sorry, not the DPP. GLP is the one that causes the weight loss. My bad. Sorry about that. GLP, please, please, please. This one is basically for the weight loss, the Ozempic one. The GLP causes the weight loss. It's very important. They can ask you if someone just wanted to do the weight loss, which good medicine is for the or which diabetic medicine helps with the weight loss. The one that is basically GLP analog. Then the ACE inhibitors and herbs in those with the any of the macrovascular diseases, age more than 55, less than 55, statins can be used if there is any hyperlipidemia or heart conditions, and then should be start with the aspirins. So I hope this much is enough, and I would like to start from the endocrinology, the diabetes from there, and then we'll come back here from dizziness. Okay. So we'll do diabetes first from endocrinology tomorrow, and then we'll come to diabetes. Oh, sorry, dizziness. Any questions from today class? Ready. I'm supposed to do this.